I open it up for questions. We have about 10 minutes left before we break, and then there's going to be some more time after we end at 1 for folks to engage with some of the manufacturers and the products that are available here to ask some more detailed questions. So, hands?
Hi, I'm Scott Becker from the Association of Public Health Laboratories. It was a phenomenal panel, and I'm a non-laboratorian as well, so I understood most of it. Some really key points that I heard, but I have a question for Dr. Dell. Could you talk a little bit about how diagnostics in the clinical community, for example, here in the U.S., impact the work of CDC and also the state public health office?
Thank you, Scott. I'd be happy to. As Todd was saying, we were talking about earlier that, there are some distinctions between what we need for clinical purposes and what we need for public health purposes. Of public health, really, we're tracking infections around in a community. We're looking for outbreaks and clusters. We're figuring out how things are transmitted, and we're getting a sense of how big a problem is it. Oftentimes these things converge, sometimes they don't converge, and I think an area that's certainly of a lot of concern and interest to us these days, where the convergence is a little bit at risk, at least in the short term, is with the development of culture-independent diagnostic tests. And here's a situation where, from a clinical point of view, this is clearly an advance. These tests are cheap, they're fast, they give the doctor and the patient a diagnosis very quickly so the patients can be appropriately treated, they really make a very big difference. From our public health perspective, however, there are some vulnerabilities that we're quite concerned about, at least in sort of the medium term. And that's because if we take, for example, foodborne illness, and there's a lot of these multiplexed enteric assays that are now really making their way out to the market, in the foodborne sphere, what we need to do from a public health point of view is we need to find outbreaks, and we need to be able to detect clusters. And the way we do that in the United States and actually around the world these days is using a network which is called PulseNet. And PulseNet uses what is now 20-year-old technology, and many of you from the diagnostics sector will laugh at this, but we use pulse field gel electrophoresis, which is like a barcoding sort of DNA fingerprinting technique. In order for PulseNet to work, we need a culture. And that culture has to be collected by the doctor when the patient goes to see the doctor, and then it has to be sent to the public health laboratory. And every public health laboratory in the United States and many around the world use the exact same method, which is standardized at the CDC and then adopted by all of the state public health laboratories to detect these clusters. At any time in the CDC, we're monitoring between 15 and 40 clusters around the world to see if they turn out to be foodborne outbreaks. So you can imagine in this scenario where there's going to be less and less reason for a doctor in a clinical setting to collect a specimen for culture, that we're actually quite concerned from a public health point of view. Now, in the long term, we're quite hopeful that with certainly our AMD initiative, that we'll actually be able to develop the new tools, leave the 20-year-old technology behind, and be able to develop technologies using bioinformatics and next-generation sequencing and metagenomics so that we too can fish the microbe out of the specimen and we don't need cultures. But in the meantime, we are very concerned and hope that we can actually work with our colleagues in the diagnostic arena to come up with some sort of a medium-term arrangement that actually keeps the clinical priorities and the public health priorities in mind, so that we maintain our capacity to protect people from, for example, foodborne outbreaks, resistant organisms, et cetera.
Thanks. I invite any of the other panelists to respond to any of the questions, but let's move on to next questions. Go ahead.
Hi, John Billings with Infectious Diseases Society of America. Thank you very much for this presentation. This is also a question for Dr. Bell, but of course welcome responses from everyone. IDSA has long advocated for a stronger surveillance system for both antimicrobial use and resistance. So needless to say, we're very excited about some of the developments. Recently, the CDC-AdvaMedDx report on resistance and the biggest threats out there. But also through legislation like the STAR Act that was recently reintroduced here in that House by Representative Matheson. So wondering if you could expand upon the importance of AV, but also just new technology and diagnostics for combating antimicrobial.
Sure, and other people may want to also comment. This actually is relevant to the question about the clinical and the public health sector. As you say, we're actually quite worried about antibiotic resistance. In our recent report, we estimate that about 2 million people a year get sick with resistant infections and that at least 23,000 people die every year. And we think this is a growing problem, and we're not really all that confident that we have a good handle on it. There are a number of areas where diagnostics really can help a lot in antimicrobial resistance. In the clinical sector, you know, the tests that are used to determine what is the appropriate antibiotic to treat a patient actually don't tell us anything about how the organism, what sort of mechanism is there, does the organism have for resistance. And we need to know that in order to be able to prioritize which are the really dangerous infections where we really have to jump on them. And so this is a situation where, for example, there are some sort of assays around, none of which are FDA approved, that would help identify mechanisms of resistance, but we really don't have access to those. And at the CDC, we're sort of the only laboratory around that's actually doing this reference testing to figure out what's the mechanism and what are the bugs that we need to worry about. And so this is an area where having the capacity to expand our ability to detect resistance mechanisms is really important. There are other areas where diagnostics are very important. We're worried about the ability of all the clinical laboratories to actually apply these assays correctly and what that might mean in terms of who gets treated appropriately for what. And so again, this I think is an area where we could really work well with the diagnostics industry. And finally, just to go back to AMD, as you're mentioning, the techniques that we're using are pretty sort of basic techniques, and we don't have the best way of understanding transmission patterns. And when we can't really see transmission patterns, we're at risk for missing outbreaks and having problems get out of hand. And so with these new technologies of AMD that many of you in the diagnostics industry are very, very familiar with, but we at CDC are really just getting our toe in the water. We see that this provides incredible potential in terms of really identifying outbreaks much more quickly, understanding patterns of resistance much more quickly, and really being able to make a difference in terms of preventing spread of these dangerous microbes around, not only here, but also around the globe.
Any other panelists want to respond?
Well, I guess I can pitch in a little. So at Abbott, through my group, we've had a partnership with the University of California, San Francisco, now for over 5 years. And so we've been applying next-generation sequencing and DNA arrays. So ViroChip is the particular one we use that represents essentially 2,000 viruses, allowing you to screen simultaneously for those viruses or in parallel. But I share some of the concerns as we move forward. For next-generation sequencing, some of it is the approach. So if one random primes and literally amplifies everything in the sample, if you don't know what you're going after, you know, that's your alternative, right? You can't look for it specifically. So then you have huge volumes of data that need to be dealt with and algorithms you need to work through to determine what is the pathogen sequence from all this background of human and other sequences that are present. And the other additional, excuse me, confounder is that in many times we see people are infected with more than one thing, right? So we'll get a hit to more than one potential pathogen. And so again, how do you make a decision, you know, based on the information you have as to what is relevant? And there are a myriad of issues, contamination, for example, you know, from run to run. We recently identified a virus that had been published on as potentially in a cohort of hepatitis patients in China. But we had found the virus actually a year earlier and come to the conclusion it was coming off the matrix of the spin columns that were being used to extract nucleic acid. So again, these techniques are so powerful. I mean, we were very excited. We assembled the whole genome in a weekend, and we're all fired up. This is going to be good. And then we realized every sample that had been processed was positive, so that's not usually a good sign. It's not a cluster. So, so anyway, I think I totally agree. There's tremendous potential, and I also totally agree that this is not something, frankly, industry on its own or maybe CDC on its own are going to be able to get their arms around. So it is something we're going to have to all try to work together and work our way through. Thanks.
Just a quick addition, these are great comments to follow on, but I think on the global stage, we don't really know what we don't know. CDC has around the world 10 global disease detection centers that, because of their support and their placement, can perhaps detect some issues that would otherwise go undetected because diagnostics aren't in place. In Western Kenya recently, they introduced new pneumococcal and Haemophilus vaccines, and those diseases have virtually been eliminated as a cause of child mortality. But now, because they had surveillance in place with cultures and drug sensitivity testing, they're picking up drug-resistant non-typhoidal salmonella as the predominant cause. So that has found a place. That's found a niche in the causes of child mortality now in Western Kenya. So unless we have surveillance systems in place, we won't know that these events are occurring. We won't know what to do in terms of what public health measures to put in place. So I think to follow on the others, we need to have systems out there to be able to monitor them before we know what to do about them. But thanks for the question. That was a great question.
It's interesting to see, I do get to travel a bit, and one of the things that's been impressive is to see how many countries have set up CDCs, even when that acronym means nothing in their language. China has a China CDC, and it means nothing in Chinese, it's just the China CDC. But they have actually done that because they have trying to emulate the amazing capacity we have here. And, I'm a layperson, and I'm not a lobbyist or an advocate. But I think sometimes we become quite short-sighted in the way that we invest in the capacities there, and we sort of think either that things have to happen within our borders to be a real risk or worthy investment, or that some of these things that are far away aren't somehow important to us. And I think these forward-leaning posts, our ability to sort of have intelligence about what's coming at us in a plane is quite important, and I think we're sometimes putting ourselves at risk, and certainly a lot of people in the developing world at risk by being a little short on some of the funding of some of these things. $40 million for 5 years is a rounding error in just about every other budget, and I hope we can do better in some of these things. And if you go down to Atlanta and you go visit the big gray building, if you can get in, there's some amazing stuff going on there, so take a trip. Next question. Brandon.
It's been a really interesting panel, and I wanted to ask Dr. King in particular about tuberculosis. So far in the U.S. this year, we've had more than a dozen outbreaks of tuberculosis in the public school system. And just a couple years ago in California, we had a case where a elementary school teacher was coughing, didn't know it was TB. It turned out to be multi-drug resistant TB, and spread tuberculosis infection to 31 children in the school near Laguna Beach. And it says to me that we really need to ramp up investment, in particular in the area of tuberculosis diagnosis. I wonder what you see as the prospects for greater investment by industry or the federal government. It's been pretty minimal compared to the HIV/AIDS investment. And the second point would be in terms of using even the diagnostics we have at hand. We have a situation in Boston, for instance, where a private practitioner wasn't even using the diagnostics correctly to rapidly find and assess the case. And so with the Affordable Care Act, obviously private practitioners, primary care physicians play an even more important role and will need to diagnose TB quickly, but are they even informed about it enough in medical training to even spot it? To even see the signs and symptoms when they're right there, and then use their diagnostics correctly.
No, those are great examples to point out, and I think our TB control strategy in the United States is slightly different than globally. We go after also identification of latent TB infection and treating that. But just the technology that I showed there with GeneXpert, that's actually been approved by the FDA and is available for use here in the United States. It's another example how global health has come back to potentially benefit the U.S. But like you say, it's a matter of getting clinicians to think TB and getting laboratory systems in place to provide that service. That's one of the drawbacks of success, too, because TB has become relatively rare in the United States because we have been successful. If you look at TB trends, they have been downward. They're largely in our foreign-born population, and that's why it's so important in the immigration screening, which Dr. Bell's group oversees through the State Department Immigration Service, why they've really upped their standards for diagnostic testing for TB, and I dealt with this when I was in Ethiopia. They picked up a lot more TB than they did before because they insisted on culture, and this new technology would be an additional technology to introduce into that process. So I think getting our diagnostic standards more and more aggressive, but also in the case of the United States, treating latent TB infection is also important in our overall control strategy. But getting health workers to continue to think TB remains important.
So when I heard, I think John was mentioning, I think the phrase used was objectivity, but I think that there's a certainly desire to see consistency, and much of that requires sort of automation, or at least taking the human factor out of as much of this as you possibly can, both for people that are here in the U.S., but also people that are abroad or traveling abroad. I just had a good friend of mine who was in a terrible bike accident in South Africa recently, went right in the emergency room and was transfused because he was bleeding profusely. If these tests are not available in that clinic he just happens to be near, because that's where his bike accident occurred, he's transfused with blood that's going to give him a bunch of pathogens he doesn't otherwise need. So this is not something that's sort of an esoteric foreign global health thing. Also, any of you from offices in the southern states know that TB is still quite an active conversation along the border states. So something there's still an active conversation in California and Texas and Arizona. Any other responses to the question?
This might not be the absolute perfect time to introduce the topic, but as we invest in improving technology that actually benefits the health systems, I think it's fair to remind the audience that we're in desperate need here in the United States of payment reform. The clinical lab fee schedule that was created in 1984 is still the same fee schedule that we have today. And in the last 23 years, I think, 15 of those years, we had either no improvement or cuts to the fee schedule. So I just remind the audience that as companies and public health agencies spend a lot of time, effort, and resource to create these next generation technologies, it would be helpful if the payment system reflected the improvement.
That's a great typical DC note to end on. We have one last question to end on, and then these folks will be around for a little bit if you have any further questions or you want to start talking about some of the detailed polysyllabic words.
Thank you very much. I'm Susan Kimball with Women Heart, the National Coalition for Women with Heart Disease. Just a quick curiosity, with all of this emerging technology and real excitement with diagnostics of infectious diseases, do you see any lessons learned that can be translated to chronic disease in terms of prevention, motivation, diagnosis, treatment?
I guess I can take a crack at it since I'm part of the diagnostics division, and infectious disease is a big part of our product portfolio, but in reality there's many other markers, and high-sense troponin is one that represents I think probably going to be a breakthrough in terms of thinking about cardiovascular disease. There's a great deal of investment in other areas, oncology, and it's sort of an interesting dynamic today between the molecular world and the serology world. Many of the tests for oncology looking for resistance or genes that would predispose one direction or another, or used in terms of companion diagnostics. We're really seeing a leaning towards molecular technologies and next generation sequencing. Some of these things that we've discussed are technologies that you will, I think, fairly quickly see adaptation, at least of panels of markers. It will take a while to move in, to have true FDA-approved products. I mean, I guess, that's the reality of all this, is that there's a lot of work that goes into developing these assays and getting performance characteristics that, frankly, you expect and we need. So it's not something that happens overnight, but there's a lot of investment in these other fields as well.
Dr. Bell?
I'll just mention the microbiome. And many of you probably just on the news have, heard about this idea that, we actually thought we knew who we were, but actually we don't know, because we're a host of billions and billions of microorganisms that live on our skin and in our bodies. And there's really a lot of growing, very interesting research suggesting that these are microbes, but they might play an important role in things like obesity, and potentially cardiovascular disease and all kinds of chronic diseases. And so this is, I think, a place where the infectious disease world, actually the infectious disease world that lives within us, there's I think, much to be discovered about the connection between infectious diseases and chronic diseases. I mean, there's a few examples of that in the past, probably Helicobacter pylori being an obvious one. This is a bacteria, it turns out, that gives you ulcers. But I think that, once again, sort of this theme of bioinformatics and new technologies, I think there's a large area of overlap between infectious diseases and chronic diseases in the microbiome that we're just really starting to scratch the surface of.
Yeah, actually, I was going to say I could extend that to the virome, which we don't hear so much
Right.
about.
No,
but
it's true.
We're actually, we have a presentation that'll be at an upcoming conference where, again, looking at blood donors, we know what specific viruses we're looking for, but doing this in a way that would essentially allow us to transect and look across and say, what else is there? And there's certainly viruses that we know are in humans. GBVC is an example that, in some cases, fairly high proportions of individuals harbor it. TTV is another virus. As far as we know, they don't cause issues. But, you can ask a lot of questions about, could it have something to do when a person is exposed? Could this be like EBV, in terms of you might have a completely different clinical outcome based on when you're exposed to the virus? And when we're transfusing from young to old or to newborns in severe cases, are we exposing them to things that right now we don't really understand what the impact is? And so I think there's a lot of interesting questions that are going to come out of this type of research, and we're barely scratching the surface right now.
So we're going to close. I just want to note, I think there's been a number of cases where we've seen vaccines that have actually been able to produce a response that actually stops the clinical progression of disease, but doesn't necessarily kill the bug. Polio being one of those, at least for some of the vaccines that are being used. So now we see people who are potentially carrying around and able to transmit something, even though it's not affecting them personally because their system is immune, but it isn't immune in the place where where the polio virus sits. So the ability to develop these kind of diagnostics that are not necessarily based on clinical results, I think is going to help us to identify carriers of these viruses that are going to help stop them in the elimination and eradication phases. Thanks for the panelists. I think we're going to have a close by AdvaMedDx. Thanks for allowing me to do this. Very interesting.
Of course, absolutely. Thank you. So I just wanted to close by making a couple of very brief remarks, and I think just to say, I hope you appreciate from the presentations not only the role that diagnostics are playing in some of these critical areas, but I think an even more fundamental takeaway is the role that diagnostics are playing across just about all of healthcare. And I hope this teased out for you not only some of those examples, but the diagnostics are, a largely underappreciated cornerstone of healthcare. And Dr. Kenyon sort of referenced that, the agency spends a lot of time talking about other areas of healthcare and not so much about diagnostics. But it's not because folks who are at CDC or in the industry or, even in healthcare don't understand the importance. But the general public, for diagnostics are largely behind the scenes. And I think even sometimes for clinicians, diagnostics are behind the scenes. We've seen tremendous examples of the kind of progress that's been driven by diagnostics, and just a hint now in this conversation around the kinds of things that diagnostics will continue to unfold for healthcare going forward. I want to say again how delighted we are to partner with CDC and appreciate the contributions of our member companies to today's event.